Welcome to this in-depth exploration of gastric sarcomas, often referred to as the forgotten tumors of the stomach wall. In a world where stomach cancer discussions predominantly revolve around adenocarcinomas, which make up about 90% of all gastric malignancies, gastric sarcomas quietly linger in the shadows, representing only 1% to 3% of these cases. These rare tumors arise from the mesenchymal tissues, the connective and supportive structures within the stomach, rather than the epithelial cells that line the organ. This distinction is crucial because it affects everything from their behavior to treatment approaches. Historically, as far back as the early 20th century, medical literature has highlighted their scarcity, with studies from institutions like the Cleveland Clinic reporting them in just 1.5% of malignant stomach neoplasms over decades of observation. Despite their rarity, gastric sarcomas demand attention because they can strike at any age, though they're more common in adults around 40 to 60 years old, and they exhibit a slight male predominance. What makes them forgotten? Well, their symptoms often mimic more common conditions like peptic ulcers or even benign polyps, leading to delayed diagnoses and potentially worse outcomes. In this 20-minute video, we'll delve into the intricacies of these tumors, starting with their definition and epidemiology, moving through the various types, exploring causes and risk factors, examining symptoms and clinical presentations, detailing diagnostic methods, discussing treatment options, and finally reviewing prognosis and future directions. By the end, you'll have a comprehensive understanding of why these tumors deserve to be remembered and how advances in medicine are shedding light on them. Imagine the stomach as a muscular sac, churning food with its layered walls. Now picture a rogue growth emerging from those very muscles or connective fibers, silently expanding until it disrupts digestion or causes bleeding. That's the insidious nature of gastric sarcomas. As we proceed, keep in mind that while rare, early awareness can be life-saving. Let's begin by defining what exactly these tumors are and how they fit into the broader landscape of gastrointestinal cancers. Gastric sarcomas are malignant neoplasms originating from the mesenchymal cells of the stomach wall, encompassing connective tissues, smooth muscles, and other supportive structures. Unlike the far more prevalent gastric adenocarcinomas, which stem from glandular epithelial cells, sarcomas develop in the submucosal or muscular layers, often growing intramurally before breaching the surface. This submucosal origin contributes to their elusive nature, as they may not immediately ulcerate or cause obvious mucosal changes detectable in routine screenings. Epidemiologically, these tumors are exceedingly rare, comprising less than 2% of all gastric cancers globally, with gastrointestinal sarcomas overall making up about half of cases in the stomach specifically. Literature reviews from case series and institutional reports, such as those spanning from the 1920s to the 1940s at major clinics, indicate an incidence of around 1.5% among malignant stomach tumors. More recent data echoes this rarity, with primary gastric sarcomas, like leiomyosarcomas, representing under 1% of malignant stomach lesions. They tend to affect individuals at a younger age compared to adenocarcinomas, averaging around 38 to 54 years, with a higher frequency in men, though cases have been documented in children as young as 3.5 years and adults up to 91. The global distribution appears sporadic, without strong geographic biases, but certain populations with genetic syndromes may face elevated risks. What sets gastric sarcomas apart is their potential for better prognosis if caught early, owing to less aggressive lymphatic spread in many types, unlike carcinomas that readily metastasize to nodes. However, their forgotten status stems from diagnostic challenges. Preoperative identification is tough due to nonspecific imaging and biopsy limitations. In essence, these tumors highlight the importance of considering rare entities in differential diagnoses for persistent gastric complaints. As we transition to types, remember that classification has evolved from early groupings like spindle cell myosarcomas and lymphosarcomas to modern immunohistochemical distinctions that guide targeted therapies. Gastric sarcomas encompass a diverse group of tumors classified primarily by their cellular origin and histological features. The most common non-GIST type is leiomyosarcoma, arising from smooth muscle cells in the stomach wall, characterized by spindle-shaped cells with high mitotic activity and positive staining for markers like smooth muscle actin and caldesmin. These tumors often present as large ulcerated masses and are graded using systems like FNCLCC, where high-grade variants show over 20 mitoses per 10 high-power fields. Gastrointestinal stromal tumors, GISTs, while sometimes categorized separately, are a key sarcoma subtype originating from interstitial cells of Cajal, identifiable by CD117 positivity, and they account for many gastric mesenchymal neoplasms. Undifferentiated pleomorphic sarcomas, formerly known as malignant fibrous histiocytomas, feature atypical, undifferentiated cells lacking specific lineage markers, making them aggressive and hard to classify. Rhabdomyosarcomas, rare in the stomach, stem from skeletal muscle precursors and are more typical in pediatric cases but can occur in adults. Malignant peripheral nerve sheath tumors, MPNSTs, develop from nerve sheath cells, often linked to neurofibromatosis type 1, and show S100 positivity. Historical classifications from mid-20th century studies divided them into spindle cell myosarcomas, including fibrosarcomas, leiomyosarcomas, and neurofibrosarcomas, and lymphosarcomas such as reticulum cell sarcomas and malignant lymphocytomas, with lymphosarcomas being more radiosensitive. Rare variants include synovial sarcomas, confirmed by SS18 to SSX fusions, and Ewing sarcomas, which are exceptionally uncommon in the stomach. Each type varies in behavior. Lymphosarcomas spread lymphatically initially, while others prefer hematogenous routes to liver or lungs. Immunohistochemistry is pivotal for differentiation. For instance, negative CD117 distinguishes true leiomyosarcomas from GISTs. Understanding these types is essential for tailored management, as GISTs respond to targeted drugs like imatinib, whereas others rely on surgery. This diversity underscores why gastric sarcomas are forgotten. Their heterogeneity demands specialized pathology expertise. The exact causes of gastric sarcomas remain largely elusive, as they arise from genetic mutations in mesenchymal cells, but several risk factors have been identified through case studies and literature reviews. Genetic predispositions play a significant role, particularly in syndromes like neurofibromatosis type 1, which increases the likelihood of MPNSTs or other inherited conditions that disrupt cellular growth regulation. Exposure to ionizing radiation, either from prior therapeutic treatments or environmental sources, is a well-documented risk, potentially inducing DNA damage that leads to sarcomagenesis years later. Chronic inflammation of the stomach, such as from long-standing gastritis or infections, may create a microenvironment conducive to malignant transformation in connective tissues. Certain chemical exposures, including industrial toxins or carcinogens, have been implicated in sporadic cases, though evidence is anecdotal. Age is a factor, with peaks in middle adulthood, but unlike adenocarcinomas linked to Helicobacter pylori, sarcomas lack strong infectious associations. Previous stomach surgeries or traumas might contribute by altering tissue architecture, fostering abnormal cell proliferation. Family history occasionally surfaces, as seen in rare cases where gastric sarcomas co-occur with adenocarcinomas in relatives, suggesting possible shared genetic vulnerabilities, though no direct hereditary links are firmly established. In pediatric cases, congenital factors or developmental anomalies may be at play. Overall, these tumors are not strongly tied to lifestyle factors like diet or smoking, differing from epithelial cancers. Research emphasizes that while most cases are sporadic, multifactorial interactions, genetics, environment, and inflammation likely drive onset. Preventing exposure to known risks like unnecessary radiation and monitoring high-risk individuals with genetic syndromes could mitigate incidence. As we move to symptoms, note that early risk awareness might prompt vigilant screening in susceptible groups, potentially unearthing these forgotten tumors before they advance. Symptoms of gastric sarcomas are often insidious and mimic more benign conditions, contributing to their delayed recognition. The most prominent is upper abdominal pain, frequently resembling peptic ulcer disease with a pain food relief pattern, especially in ulcerated tumors, seen in about 2/3 of cases. This pain can intensify over time, becoming constant without remission, signaling malignancy. Gastrointestinal bleeding manifests as melena, black stools, or hematemesis, vomiting blood, sometimes leading to acute hemorrhage and shock as the tumors erode vessels. Unintentional weight loss is common, averaging 20 to 30 pounds, accompanied by anorexia, weakness, and fatigue due to chronic blood loss or tumor burden. Nausea, vomiting, and a sense of early satiety or bloating arise from mass effects obstructing gastric outflow. In advanced stages, a palpable abdominal mass may be felt, particularly in exogastric or large tumors. Anemia from occult bleeding is frequent, with hypochromic features on labs. Less commonly, perforation can occur, causing acute peritonitis, or the tumor might cause gastric outlet obstruction. Unlike adenocarcinomas, sarcomas produce less cachexia and systemic wasting early on, and symptoms duration averages 10 months before diagnosis. Presentations vary by type. Lymphosarcomas often ulcerate and bleed, while spindle cell types grow submucosally, delaying symptoms. In rare pediatric cases, symptoms might include failure to thrive. Physical exams may reveal pallor, tenderness, or emaciation, but no specific signs distinguish them from carcinomas. Literature notes severe pain as cardinal, with bleeding more massive in advanced disease. These nonspecific manifestations underscore why sarcomas are forgotten. Patients might be treated for ulcers or gastritis initially, allowing progression. Recognizing changes in chronic symptoms like worsening pain or new bleeding is key to prompting further investigation. Diagnosing gastric sarcomas is challenging due to their rarity and submucosal location, often requiring a multimodal approach. Upper endoscopy is the cornerstone, revealing polypoid, ulcerated, or infiltrative lesions, but superficial biopsies may yield false negatives or misdiagnose as benign polyps, as seen in cases where deeper tissue is needed. Endoscopic ultrasound enhances accuracy by assessing depth and vascularity. Imaging plays a vital role. Contrast-enhanced CT scans detect mass size, location, and metastases, showing irregular, enhancing tumors without typical adenocarcinoma features like nodal enlargement. MRI provides better soft tissue detail, useful for invasion assessment. Upper GI series historically identified filling defects or hypertrophic rugae, though less used now. Laboratory tests include blood work for anemia, occult stool blood, and gastric analysis, where acidity varies but achlorhydria occurs in some. Definitive diagnosis hinges on histopathology and immunohistochemistry from biopsies or surgical specimens. Markers like actin for leiomyosarcomas or CD117 for GISTS differentiate types. Grading systems like FNCLCC evaluate differentiation, mitoses, and necrosis for prognostic staging. Preoperative distinction from carcinoma is tough. Röntgen exams often suggest neoplasm without specifying sarcoma, and gastroscopy describes nodular ulcers or polypoid masses. In ambiguous cases, exploratory surgery or metastatic biopsies confirm. Literature emphasizes that positive diagnosis requires careful histologic exam, as frozen sections may fail to determine malignancy. Modern tools like genetic testing for fusions, e.g. in synovial sarcomas, add precision. Early diagnosis improves outcomes, but delays stem from nonspecific findings, highlighting the need for high suspicion in persistent symptoms. Once diagnosed, staging via AJCC-TNM considers size, 5 centimeters pore, and metastases, guiding therapy. Treatment for gastric sarcomas centers on surgical resection as the cornerstone, aiming for complete removal with negative margins to prevent recurrence. Procedures range from partial to total gastrectomy, often with en-bloc excision of adjacent organs if invaded, and Roux-en-Y reconstruction for continuity. Lymphadenectomy is selective. D1 dissection suffices since nodal metastases are rare, under 15%, except in lymphosarcomas. Systematic removal isn't routine, unlike in adenocarcinomas. adenocarcinomas. For localized tumors, R0 resection offers the best chance of cure. Adjuvant therapies have limited roles. Chemotherapy, e.g., doxorubicin-based, is marginally effective, used for high-grade or recurrent cases, while radiation provides palliation for unresectable tumors or symptom control, though sarcomas vary in radiosensitivity. Lymphosarcomas respond better than spindle cell types. Targeted therapies shine for GISTs with imatinib inhibiting KIT mutations, but non-GIST sarcomas lack such options. Immunotherapy is emerging but not standard. In historical series, combinations of surgery and Roentgen therapy yielded longer survivals, with individualized approaches recommended. Biopsy first for upper stomach lesions to guide radiation if radiosensitive. For advanced disease, palliative measures address bleeding or obstruction. Post-operative care focuses on nutrition and monitoring for complications like dumping syndrome. Literature stresses that surgery alone can control even high-grade cases if margins are clear, as in reported 28-month recurrence-free follow-ups. Challenges include operative risks in large tumors, but minimally invasive techniques are evolving. Overall, multidisciplinary teams, surgeons, oncologists, pathologists optimize plans, emphasizing radical yet conservative resection to preserve function. This approach underscores why outcomes are better than for carcinomas, provided early intervention. The prognosis for gastric sarcomas is generally more favorable than for gastric adenocarcinomas, with 5-year survival rates ranging from 16% to 68%, influenced by tumor size, grade, mitotic rate, and resection completeness. Poor predictors include tumors over 5 centimeters, high-grade histology, e.g., 20 mitoses per 10 fields, metastases at diagnosis, and incomplete margins. Recurrences hit 36 to 60%, often hematogenously, to liver or lungs within 2 years. Low-grade, small tumors boast better outcomes, with some cases achieving long-term cures post-surgery alone. Historical data shows 5-year survivors primarily from combined surgery and radiation, especially in lymphosarcomas. Modern factors like Chi-67 proliferation index, e.g., 40% indicating aggression, further refine predictions. Regular follow-up with imaging and endoscopy is crucial for early recurrence detection. In conclusion, gastric sarcomas, the forgotten tumors of the stomach wall, remind us of medicine's complexities. Rare yet impactful, they challenge diagnostics but offer hope through surgical advances and emerging therapies. By raising awareness, we can shift them from obscurity to priority, improving detection and survival. Future research may uncover genetic targets or immunotherapies, brightening prospects. If you or a loved one faces gastric symptoms, consult specialists promptly. Early action could make all the difference. Thank you for watching. Remember, knowledge empowers health.